Dr. Kahan, I mean, I'd like to introduce you to some of our listeners. Obviously, you're a member of the American Board of Obesity Medicine. You're an author. You're really an advocate for all things public health and policy, right? So we're able to snag you for about 20 minutes today. And it caught my attention that states, some are providing these GLP-1s to their constituents, to their voters. And I want to take a macro view, a step back. How did we get here?
So it's been a winding road, and so if you go back just a few years, obesity was not considered by most to be a real medical condition. It was not considered by most policymakers to be something that is worthy of being treated in the healthcare system, in Medicare and Medicaid, et cetera, of having treatments covered for it. Generally, people, policymakers, lay people, and doctors as well, thought of heavy people as just not trying hard enough, maybe not being smart enough or having enough willpower, not caring enough, and therefore it's up to them on their own to pull themselves up from their bootstraps and do something about their health. And a lot has changed over just the past few years and the past decade or two. On the one hand, we've learned a lot more about the science of obesity, and importantly, there's been great communication of that science out into society, to policymakers, to doctors as well, and lay people, so that, and it is a very complex science, it's a very interesting science, and importantly, it's every bit as robust as the science around other health conditions, heart disease and diabetes and cancers and so forth. And the complexity that we've learned about weight regulation and obesity, similarly, is every bit as complex and interesting, frankly, and challenging as with other diseases, maybe even more so. And so, on the one hand, from that perspective, there's been more interest in actually treating obesity. There's been more consideration of treating obesity, covering treatments for obesity, and so forth. In parallel with that, while the GLP-1s have been developed over the last 2 to 3 decades and came to market over a decade ago, it was really around the time of the pandemic that they got a lot of attention. For one, the newest GLP-1s for obesity came to market, were approved, and they are much more effective than the medications before them, both the GLP-1s before them and non-GLP-1 medications before them. And there also, there was just this sort of perfect storm of media attention and so forth that combining all these things together led to a lot more attention to obesity, interest in addressing obesity from the patient perspective, the policymaker perspective, and the physician perspective. And so now we're in this situation where overwhelmingly patients are more interested in doing something about their weight, and potentially also doing something more than just going on a diet or exercising. Certainly those things are still very important. Physicians who historically don't get any training in obesity and historically are not interested or feel comfortable to treat obesity, they are now much more interested in either treating themselves or referring to specialists like me and others to do that treatment. But rather than just shooing patients away, they're more interested in guiding patients in with respect to weight management. And policymakers are also much more interested in the possibility of coverage. But of course, as you know, there's a lot of challenges in terms of using the medications, in terms of covering the medications. They're very expensive, and in terms of integrating them within the larger healthcare system.
Well, and you mentioned that the intersection of health and policy, which is exactly why we asked you to come on the show. From a patient's perspective, where I am confused, a blanket statement, by the way, I'm confused often, is that you have all of these different states who have, obviously, funds are being cut from the federal government, right? So we have that. But then you have the president just recently saying that he was going to lower the costs so that it would be more accessible. And that was, he was working straight with the drug maker. So then you think to yourself, well, I'm on Medicaid. Now it's going to be cheaper. It's more accessible. because a lot of people and overweight or underweight are, and even now I see the dad and the frame in the back of your shot here. I mean, I'm hearing reports of kids being on this medication. So it really knows no boundaries at this point, people taking this medication. So if there is an accessibility issue here, that's also what I want to get to the heart of. Every state is different, right?
In terms of Medicaid, each state Medicaid program is different.
Right.
They cover things in different ways. They have different budgets and so forth. And look, I'm hopeful that the announcement by the Trump administration that there will be lowered costs for these medications in the near future. I'm hopeful that that will come to fruition. But again, we don't know that. We don't know the fine print. We don't know when that might happen. We don't know to what extent prices might be lowered and for whom it might be lowered.
Exactly.
As I read that announcement, the first population was the Medicare population, where we would hopefully have better access. Till now, there is no access by law for obesity medications in Medicare, whereas in Medicaid, because it's a state by state decision, some states do have coverage, some states have little bits of coverage, some more, and some have none. But we don't know whether that will apply to Medicaid as well. We don't know how it will apply to patients outside of government programs, outside of Medicare and Medicaid. And we don't know to what extent it's going to lower prices. I'm no expert in Medicaid by any means, but what I understand is that the lowered prices that the administration has talked about aren't necessarily lower than what Medicaid programs have been paying already. And that's still a very high cost when you're talking about such a wide population of people that qualify for access to the medications.
Yeah, I think if I remember, there was a political article. It was like $245 a month, and I could be completely wrong because I don't have my notes in front of me. But I'm not sure that really, like you said, is a big price drop, if at all. It might just be the same. You've worked in this industry. Blue sky it for me. What do you want to see when it comes to accessibility and then usage of this medication?
So first of all, we're not talking about a medication. There's a number of medications that are approved and effective for obesity management. Some of them are GLP-1s, some of them are not GLP-1s. The two most effective medications for obesity management in terms of weight loss as well as other weight-related health improvements are one called Wegovy and another called Zepbound. But there are others as well. You know, biggest picture, I would like to see obesity treated like other medical conditions, like hypertension, like diabetes, etc. Which is to say, on the one hand, um, eating healthy, exercising, living a healthy life, learning about living a healthy life and being counseled and supported in that, those are important for all of those conditions, whether diabetes, whether obesity, whether hypertension. So that's certainly part of the approach. But when you look at the standard of care, both in the guidelines and also on the ground in treating hypertension or diabetes or the like, that includes when indicated and when seemingly helpful, that includes effective medications for those conditions. With respect to obesity, it's hit or miss. Sometimes it includes that, often it doesn't. The guidelines certainly say that medication should be an escalatory option for appropriate patients, but on the ground, that far more frequently than not, that doesn't happen. Now, with all that said, we have a very fragmented healthcare system in terms of payment, in terms of delivery, et cetera. And I think that part of this goes to the how obesity care fits within the broader healthcare system, and it's a very very challenging thing, both in terms of addressing the obesity itself, in terms of getting access to treatments for obesity itself, but also in terms of how it fits within the broader system. So this is not as simple as just saying these are good medications and everybody should be on them and let's make them cheaper. Unfortunately, it's a bit of a quagmire, I think.
Well, quagmire, and that's actually what came to my mind when you compared obesity to something such as hypertension. I could be wrong and make just a blanket statement here. Doctors aren't trained generally to properly treat obesity. True or false?
By and large, that it's entirely true. That certainly was true a few years ago. We've been doing a better job at getting obesity science and obesity practice into medical school and other healthcare professionals' curricula. So new doctors and doctors of the future will be more comfortable and expert, frankly, in addressing obesity. But today's physician workforce, as well as today's psychology workforce and even dietetics workforce, are far less commonly trained in the nuances of obesity management. And so there's some primary care doctors that learn on their own, or that are able to get some training in that. There are some people that specialize and have a background in obesity management, like myself, but that's quite a few people nationally. In the context of how many hundreds of millions of people potentially are either suffering from obesity or at risk of it.
I'm going to make another blanket statement, and you can tell me if I'm right or wrong. It's a very complicated issue, but GLP-1 medications are just a piece of the puzzle, but they're also a prevention piece of the puzzle. So I'm not necessarily an advocate, or I'm not promoting expanded Medicare or Medicaid, because I'm not taking a side here. This is a medication that every state should be investing in because it'll simply prevent other diseases and it should be more accessible. But then you have the devil's advocate that says, conspiracy theory, Americans are sick. That's what makes the world go around. We prescribe them medication.
Which gets to part of the central problem of our healthcare system,
Right.
where we tend to do a better job at treatment than we do at prevention and helping people stay healthy. And that's not only a problem with the healthcare system; it really is part and parcel of the society that we live in, and not only America, much of the Western world. So I think it is extremely important for people in need to have access to obesity, to evidence-based, smart, thoughtful, and expert obesity management. Now, that includes pharmacotherapy, medication treatment, as well as other treatments like counseling for diet and exercise, potentially bariatric surgery for appropriate people as well. And within pharmacotherapy, that includes GLP-1s for some patients. Not, GLP-1s are not the be all end all. There are additional medications, and we don't want to simply pigeonhole as GLP-1 or nothing. Many people get extremely great benefits with the newer GLP-1s. Many people get great benefits with some of the older GLP-1s, and many people get great benefits with the non-GLP-1s. So there's a number of options that are available, with the newer GLP-1s being on average the most effective. But access to, again, evidence-based obesity treatment is really key here. I think there is a little bit of we need to put an asterisk when you talk about prevention with respect to the medications. So these medications have been approved explicitly to treat obesity, as well as people who are overweight with at least one weight-related health condition like hypertension, diabetes, and such. Some of them are also approved to prevent some things. So, for example, Wegovy, one of the GLP-1s that I mentioned before, is also approved to prevent a heart attack in people that already have known cardiovascular disease. And now we also have some degree of data that these medications can prevent a range of things. So the newer GLP-1s, for example, do a very good job at preventing the development of diabetes in people who have obesity and prediabetes, but they're not explicitly approved for that necessarily. So there are some policy issues that we need to be careful with. But as a whole, in general, addressing obesity does tend, in theory, to lower the risk for developing a whole number of potential weight-related health conditions.
Can you expand a little bit on those policies that we need to be careful of? I think one of the things that I find most fascinating is the intersection of health and policy. So what would you like to see? How are policies good and bad? Are we getting it right and we're getting it wrong?
I'm not one to say that we're getting it right or wrong, but for example, um, uh, a longstanding area of disagreement has been that FDA doesn't recognize prediabetes as a treatable condition, and so lots of doctors like myself. We've seen the data and we've seen in our clinical experience as well that if we can treat patients with prediabetes earlier, sometimes with weight loss and sometimes with medications that have been shown to prevent the development of diabetes. Some are diabetes medications, some are obesity medications. That we can do a very good job at keeping people from developing diabetes and potentially even reversing the prediabetes. The FDA does not recognize, however, prediabetes as a medical condition as of now. So there's not currently coverage, insurance coverage for treating prediabetes before it gets to diabetes. And similarly with people who are at risk for obesity, unless they meet the explicit criteria for obesity medications as it's laid out now, they're not eligible for those medications. And in some cases, they may be able to prevent obesity from coming on. There's still a lot, and I'm not saying that the FDA is right or wrong with that, but I think there's more to be examined and considered with the possibility of sort of going upstream and trying to address these conditions before they fester into more severe later stage conditions. That's not all going to be medicines. That is a lot of that has to be a public health approach where there's easier access to healthy foods, where there's better counseling and support for healthy lifestyle, where there's better abilities for people to be active in the course of their day to days. So all of this has to be part of it. Some of it is economic, some of this is policy wise, but I think it really needs to be a broader approach aiming sort of top down and bottom up if we're realistically going to make big progress here.
Yeah, I mean, I know we're getting close to time, but I wish I could sit down with you for 20 more minutes and ask you, why after one of my kids' sports games, they're offered Swedish fish and red juice and Gatorade I remember when we were kids, it was orange slices. So I could really dig deep into some of the root of the cause here, but I know that your time is valuable. So I think my last question is, as a consumer, I'm looking at this MAHA movement. I'm looking at Health and Human Services Secretary RFK Jr. doing pull-ups and jeans. And then I've got Elon Musk, who by no means is not part of Health and Human Services, but he's saying that, everyone should have access to GLP-1s and other weight loss medications that should be on the shelves of a grocery store. Exaggeration. He didn't say that. I put those words in his mouth, but you get the idea. Why? I'm confused. I said that earlier. I'm getting a lot of mixed signals. I'm getting states that have more coverage than others, yet there are prevention measures to this medication. What am I to believe? Are we on the right track here?
So look, I think on the one hand, we are most certainly going in the right direction. Where we are with respect to obesity today is leaps and bounds ahead of where we were 5 years ago, a decade ago, 2 decades ago. I mean, it is unrecognizable how much further ahead we are today than we were a decade or two ago. So we're going in the right direction, but still, literally over 100 million people are left without the kinds of support and treatments that ideally they should have access to. So we have a lot of challenges. I would recommend not getting your advice on obesity or obesity treatment from social media. And this is a challenge. And you heard throughout this discussion that we have here that I work very hard to try to temper the challenges we have at access, the importance of better access, et cetera, but also with the irrational exuberance that has been very common in social media and elsewhere, whether around the medications, whether around other aspects of obesity management. And I don't think that's terribly different. This may be a more extreme example, but I don't think that's terribly different with a lot of things in society. What's the old saying with in figure skating where they sort of lop off the judge over here and the judge over there, and they look at the scores in the middle. I think that's pretty important. There's crazies on this side, there's crazies on that side, and there's a lot of good information and a lot of good contextualized important discussion, in the middle. And I'm not even saying that as a political thing necessarily, but there's a lot of bogus stuff out there where we're being pulled in all different directions with respect to medications and obesity in general. And it's really important to be able to cut through that noise. And so, look, I think, people like you that are able to communicate to large audiences are really important within that. I think, policymakers that have bully pulpits are important people in this to communicate around the real science and the real aspects of this, and not the myths, not the pseudoscience. And so we're going to have to do a really good job at that going forward. But again, we're going in the right direction.
I love that, because as a parent, sometimes you feel as if we're too late, and you feel as it's an uphill battle to get nutrients in your kids these days. And, we don't live on a farm, and I can't prevent them from everything that they eat every day, nor should I. They have their own little lives. But it feels disheartening sometimes as a parent. Like, you're thinking, I'm already screwed. We're already late. So I actually appreciate your perspective, Dr. Kahan, and I hope that you'll join us again. It's an ongoing discussion. Parents are really interested. So thank you for your time, sir. Appreciate you.
Thank you for doing this.